They're just, I'm always fearful that I'm going to trip on the way up.
Well, if you are, at least you're in the hospital.
But I would look silly.
I gave a talk years ago at a hospital in St. Louis.
Oh, God. Okay, guys, why don't we go ahead and get started? Before I introduce today's speaker, I realized that last week I completely and totally forgot to announce the top attendees attenders, at Medicine Grand Rounds for the month of September. Remember that each one will get a gift card to Panera. So these are Robert Emmons, Henry Sadlow, Stephen Winters, Burt Watson, Forrest Arnold, Anupama Raghuram, Tom Dews, Jen Cook, Tyler Sharp, Clay Smith, and Lori Wagner. So each of you guys, Jason Puckett, will have your gift cards. So I decided that this has been such a wild success that I'm just going to sweeten the pot. So now that know that one of the gift cards every month is actually going to be worth considerably more than the ones that I've been giving out. So, increase your chances for more than one visit to Panera Bread. Okay, Medicare for All. It is Elizabeth Warren's running on it. Bernie Sanders is running on it. It's excited a whole lot of discussion and furious debate, particularly in the presidential campaign arena. So I'm thrilled today to introduce our lecturer, Dr. Gerald Friedman, from University of Massachusetts Amherst, who is an economist there who will be speaking about Medicare for All. He did his training at Columbia and Harvard, and was at Tufts and currently is at UMass in Amherst. He is extraordinarily well published in the field of health economics and, as far as I can tell, presidential involvement, in health economics as well. The lecture that he is giving is the George W. Pedigo lecture. The University of Louisville has a really rich history of having named lectures, and George Pedigo was a native from Kentucky, from Glasgow. Actually, I think he was born in Barron County, who got his MD at the University of Louisville, went into the service from 1943 to 1946, and then after he got out, came to the University of Louisville and joined the faculty in internal medicine. It was interesting to me reading his CV that he was board certified in internal medicine in 1945 and recertified in 1974, which I think is really, quite remarkable. I think that we could all say that this guy would have been grandfathered in. He elected, to recertify. He was extraordinarily involved in the, I guess you would say, the politics of medicine. He was a big figure in the ACP, the Kentucky chapter of the ACP. He was governor of the Kentucky chapter of ACP, and also was an overseer for the University of Louisville as well. I'm thrilled that our lecturer today, I think that fulfills what Mr. and Mrs. Robert Hooke, who were the ones that donated the money for the Pedigo lecture, what they were looking for in a speaker for this lecture. And with that, please join me in welcoming Dr. Friedman.
Thank you so much. Oh, the lights are going down. Okay. Oh, got to turn this on. Oh, I got that. I don't. Oh, Jason. Did the battery die? Hope not. Well, thank you, Dr. Lederer, for the very generous introduction. And thank you all for having me here. Oh, something's working.
There we go.
Oh, there we go. Okay. Okay, great. Okay, here's the roadmap of my talk. We're going to talk about U.S. healthcare, how we're doing as a country, and compared to other countries. I'm going to talk about how changes in the way we finance healthcare in this country have made our system worse. Worse for patients, worse for people paying the bills, and worse for doctors. And then we're going to talk about how improved Medicare for all would work, how it could be financed, and how it would affect your lives as physicians. First, how the U.S. healthcare system compares. And this graph is, if you get nothing else out of a talk that I give, I tell people, remember this graph. Life expectancy on the vertical axis, healthcare spending per capita in log terms. So, every going up is a doubling in spending. So healthcare spending in log terms and life expectancy. Now, when I was in graduate school, we had a seminar I used to do to economics of slavery and demography before I became a labor historian and an economic historian, and then I became, the healthcare person. But we had a seminar with several Nobel Prize winners, and one of the people who came to talk was Richard Zeckhauser, who had been a health care advisor to Presidents Nixon, Ford, Carter, Reagan, and Clinton. And he was head of the Kennedy School of Government. Zeckhauser came and he told us that this 1982, healthcare spending was a waste. It did nothing to raise life expectancy or improve health. People go to the doctor as a consumer activity like skiing. Grandma goes to the doctor when she's lonely. The problem of healthcare costs in the United States, Zeckhauser has said, and this is a man who was one of the top people advising the U.S. government on healthcare in the 70s, 80s, into the 90s. The problem of healthcare is people do not pay for healthcare on the margin. You go to the doctor, you're not paying the full cost. So people abuse, that was his word. Martin Feldstein, who shortly after his talk became head of the Council of Economic Advisors under President Reagan, came and explained that all the improvements in healthcare and life expectancy in the United States were due to clean water and better nutrition. What doctors do is a consumer activity. He didn't say the skiing thing, but he meant it. And it's all waste. Well, guess what? These economists are wrong. This graph shows why they're wrong, or shows that they're wrong. You increase spending everywhere else. Each diamond here represents a member state of the Organization of Economic Cooperation and Development, the Club of the Rich. These are affluent countries. In every other country, this regression line shows that life expectancy increases when you spend more on health care. I mean, of course there's waste in the system everywhere. There are people who get care that they don't need. The Institute of Medicine has estimated that maybe $300 billion what we spend is unnecessary or wasteful care. Sure, but on average, in other countries, when you spend more, you get an outcome of better life expectancy and less morbidity, better health in general. People are taller where you spend more on health care, except for one country. Here's the United States. We spend the most. We spend almost 50% more than any other country. And yet, for all that spending, we have life expectancy comparable to Chile. Chile's a nice country. I don't have anything against Chile. But if we're only going to have life expectancy comparable to Chile, then why are we spending so much money? Or to flip it around, if we're going to spend all this money, why don't we get the extra 6 years of life expectancy that we should get for that expenditure? At this point, they usually ask people, do you want the money or do you want the life? And in those surveys, the gray-haired people like me always go for the life. The students with their debts and everything go for the money. Yeah. Okay, so what's more, we're doing worse. Relative to the rest of the OECD, our life expectancy is dropping. Yeah. Back in 1995, as recently as the Clinton administration, well, we were spending a lot more, but at least we were average in life expectancy. Now, with over a year short of the average, compared to Japan, which is first in the world in life expectancy, we're about 8 years short. Yeah. And guess what? We also don't go to the doctor. People will tell you that the problem of healthcare expenditure, spending so much in healthcare in the United States, we use too much. No, we don't. Yeah, we have more cesareans. We do have more MRIs than other countries, though, yeah, sometimes that's an alternative to something more expensive, so that's not necessarily so bad. Yeah, but otherwise, across the range in procedures, we have less utilization than other countries. We go to the doctor 2 times per year less than the average for the OECD. You know who goes the most? The country I just mentioned, the Japanese. They go on average once a month, 12 physician visits per capita in Japan. And they live a lot longer than us. You could say maybe all that time they spend going to the doctor balances out or, yeah, whatever, but still. Here we go 4 times per year. And we're actually going less than we used to. Here's why. This is surveys by the Commonwealth Fund of people reporting that they could not do something because of cost. They could not go to the doctor. They could not fill a prescription. They could not have a follow-up visit with a specialist. Almost a third of Americans report some financial barrier to access. A quarter of Americans, over a quarter, report that they walked out of a physician office with a prescription and they did not fill it or they stretched it out. You hear these stories of people, with insulin. There have been a whole bunch of stories since the price of insulin has been soaring in recent years. People walking out of, walking out of the physician office, not filling their insulin prescription. What do? They stretch out their old insulin. Well, you know what you call people who don't fill prescriptions that they need? You call them dead. Which is exactly what we see in this country. Each diamond here represents a county. There's the regression line. Along here, we have the proportion reporting cost access problems. And on the vertical axis, we have age-adjusted mortality in the county. Again, guess what happens when people can't go to the doctor? They die. The only people who would be surprised by this are economists. You could go on. Here's Kentucky. The same finding. Almost exactly the same R squared. Within counties in Kentucky, those where more people report they can't go to the doctor because of cost, more people die. Again, the only people who would be surprised by this are economists. By the way, Steckhauser skied a lot. He was very good. I was doing cross-country then. I was a graduate student, didn't have the money. Now, until recently, I would downhill too. But if you visit me in Amherst, I'll show you where you can go cross-country skiing. Okay, here's gains in life expectancy. Because not all Americans are doing worse than other people. The richest Americans have life expectancy as good as the average for most countries in the OECD. Here's the change in life expectancy over these 20 years. This is life expectancy at age 55. So they're using Social Security data. One of the problems with health, with studying health in the United States, is we don't have good longitudinal data that is changes over time, the population except for the VA and Medicare. So you'll find most of these studies are done for those people. One of the advantages that I don't quantify the dollar value of this, but one of the advantages of Medicare for All is everybody would be in one system over time. So we can actually study better what works and what doesn't work. Anyway, this is for the for the Social Security population. Change in life expectancy age 55. With rising inequality, economic inequality, and changes in the way we finance healthcare, the rich are doing better and the poor are doing worse. Life is something that money can buy, and the rich live and the poor die. You know, the poorest men are still at least they've gained a little bit. But the poorer women have lost ground. The 40% of women, the lower economic 40% of women actually have shorter life expectancy now than they did 20 years ago. The first time I reported this, I took it from a paper in the Brookings Papers on Economic Activity. The first time I reported it at a talk I gave in Oregon, I expressed bewilderment. How could this be? With all the improvements in medical technology, how could women not be doing better? Afterwards, somebody who came up to me, she works in a food bank. She said she had no problem understanding it. Women who go to a food bank, poor women, they feed their children first. And then, if anything's left, they eat. You fill a prescription for your children before you fill it for yourself. So poor women are sacrificing themselves for their children, which any mother would do. The problem, of course, is they don't have enough. And that's what's killing them. Healthcare finance interferes with providing care, and it's been getting worse with what I call the market turn healthcare policy, because we started listening to the economists. The ideas that the economists brought to the table. We need more competition. That will lead insurance companies to do a better job, become more efficient in bill processing. You know, stand up to monopolies in the drug, in big pharma and hospitals. Bring down prices. Let the insurance companies compete. Insurance companies have failed at this. Instead, what insurance companies do is utilization review and adverse selection. They go after the patients and they go after the doctors. They spend a lot of money doing that, and they drive you crazy. You know, they drive you to burnout, but they don't save money. Okay, what do insurance companies do? Adverse selection. There's a famous paper by Kenneth Arrow, won the Nobel Prize in economics. It's one of the most widely cited papers in economics. Like Mark Twain's definition of a classic, I think people talk about it without reading it. If they read it, they'd know that what insurance companies do is they profit from waste. There's the 70-10 rule. 70% of your costs, your medical losses. That's what they call it when they spend money on health care. Your medical losses. They have the medical loss ratio. The Wall Street Journal has the medical loss ratio, and they say, oh, it went up for some company, so their stock price is going down. We should call it the care ratio. How much money are they actually spending on care? Because that's what we want. We want health care for our premiums. Well, they look at it and they say, oh, if we can find those 10% of the people, make them go away, we'll increase our profits. My father in the coffee business tried to make better coffee so people would drink more. If he had been in the insurance industry, he would have been trying to find ways to get rid of, lemon drop, the 10% who are expensive. and cherry pick the young and healthy people. Where do you advertise if you're an insurance company? Do you advertise on the ski slopes or do you advertise in the nursing homes? Of course, your fiduciary responsibility is to lemon drop, get rid of the people going to the nursing homes, and cherry pick, get those young, healthy people in here and get them to pay premiums because you'll profit from them. Okay, so why is healthcare getting so expensive? The big reason is prices. Here's a study from California, but it's a national phenomenon. Private health insurance has failed to control hospital prices. Hospital prices have been soaring in the last 20 years, and private health insurers can't control that. Tufts Health Plan in Massachusetts, the CEO is James Roosevelt, grandson of Franklin Roosevelt. He decided to do the right thing. Well, first of all, at the Health Insurance Association convention, he filed a single payer proposal. It didn't get a second, so it didn't happen. But anyway, Tufts tried to do the right thing. They went to partners, Massachusetts General Hospital and the Harvard teaching hospitals, and they told them, we're not going to accept your exorbitant rates. You are charging 6 times as much for the same procedures, 5-6 times as much for the same procedures as everybody else. You charge $2,000 for an MRI that costs $500 someplace else. Partners told them to take a walk. Within 48 hours, so many subscribers to Tufts Health Plan had threatened to walk out that Roosevelt went hat in hand back to partners and surrendered. Private insurers can't regulate prices because the hospitals and the big pharma have market power. They can walk away from a single private insurer. Private insurers can't walk away from them. And with consolidation in the hospital industry, these hospital networks have more market power, and they're using it to drive up prices, and we're all paying for that. Prescription drugs. God, I don't even need to talk about this. Even the Trump administration, whose head of Health and Human Services is an Eli Lilly executive, even the Trump administration says drug prices in the United States are twice as much as elsewhere. But you know what they say? The problem isn't that we have prices too high. The rest of the world prices are too low because Eli Lilly cannot make as much money in Italy and Britain as it does in the United States. Oh, well. What happens when you can't afford your drugs? You die. Here's the price of insulin in the United States and in other countries. Diabetics don't die in Japan because they can't get their insulin. Only in the United States. By the way, who invented insulin and how much did they charge for their patent? It was invented by 2 guys in the University of Toronto and somebody using ideas from somebody in Scotland. They donated it, like Jonas Salk. They donated their patent to the world because they thought nobody should die because they can't get insulin. Okay. Insurers do try to regulate prices, but when they do, they make things worse. They go to physicians and they say, well, if you want us to send our patients to you, our clients to you, then you have to accept our prices. After all, your market power depends on your ability to walk away. So they say, we will walk away from you. We won't let you in our network. Well, what happens to patients when their insurance company walks away from some doctor? It disrupts their care. The patient-physician relationship is vital for successful health treatment. We all know that. You have to have a good relationship with your patients. You have to know them. They have to know you. Well, you're dropped out of the network because you won't accept their prices, and bammo, your patients have to go somewhere else. Your patient's insurance changes. Bammo, they have to go to a different doctor, one who doesn't know them. They're treating you like an automaton. like a computer program that's interchangeable. One doctor just as good as another, or just as bad. Utilization review. They tell you what to do. Or to quote a friend of mine, I have to call some snot-nosed high school graduate in Omaha who knows nothing about my patients, and he tells me what to prescribe. It drives people crazy, as well it should. By the way, here are the forms from my side. This is from physical therapy 2 years ago. I had to sign my name 11 times. I handed the papers into the PT place, and I pointed out to her, nice lady, I pointed out to her that she works for Partners, the Harvard Teaching Hospital monopoly. My physician works for Partners, and the specialist, the foot specialist, works for Partners. So why on earth do I have to sign my name 11 times and fill out all this paperwork? Why can't you guys talk to each other through your electronic medical records? What a joke. They weren't integrated. So I tell this story the following January because, of all things, I was invited to debate Ezekiel Emanuel at Coconut Grove, where the hotel rooms cost almost $1,000 a night. Fortunately, they paid for my hotel. Otherwise, I wasn't going. It's nothing special. They have a marble shower with 2 heads. That's kind of like, and a good view. Okay, so I tell the story. Afterwards, the head of Partners comes up to yell at me because I had singled out Partners again and again and again. And he says, we now have integration with the Epic system. How many of you have worked with the Epic system? Oh my God, my doctor hates the Epic system. She does her pajama work time every night. She has 3 children. A wonderful person. I love her. She grew up 2 houses over. Took the school bus with my daughter. But anyway, I love her. But she spends as much as 3 hours a night after putting her kids to bed filling out the boxes. Because if you don't fill out every box, including the box that she has to check, that I am not HIV positive, I am not diabetic. Again and again, she has to check these boxes every time I see her, because if she doesn't check them, then the insurance company is going to return the thing and say, we're not paying. You didn't do proper medical care. You didn't check whether he's HIV positive. I mean, of course, you need to know whether your patient's HIV positive, but you don't need to check it every time you see the person. Okay, here's the insurance form. This is invoice template, but of course, every company has its own forms. So you drive people away, you raise the copays, you raise the deductibles, they don't go and get care. Well, if they have COPD, you know what? After a year or 2 not seeing the doctor, they often get sicker. Each of these is a linked study. If you ever want my PowerPoint, I'm happy to send it, and then you can follow the links yourself. But if you're in a high deductible health plan where it costs you more to go to the doctor, you don't go, and you may end up in an emergency room. Women with breast cancer, if they have a high deductible health plan, higher copays, high deductibles, they don't go to the doctor as frequently, especially if they're poorer, lower income. They don't check out those lumps. You know what? They get treated for cancer later. And what happens to people who get later cancer treatments? We call them dead. Chronic conditions like diabetes use less medical care. This is exactly what the economists wanted because they said healthcare is useless. Well, you know what? It's not useless if you're diabetic. It's not useless if you have cancer. It's not useless if epilepsy, multiple sclerosis, or my condition, the arthritis. You delay care, skimp on medications, die, or become more expensive. Improved Medicare for all would save money, lead to better health care. And you know what? I'm an economist. I'm not a doctor. Well, I am. They call me doctor. That's very nice of you. But my concern is for the economy, because that's what I do, but it also would help you. And yeah, I guess I do care a bit because, a majority of the students in my freshman class at Columbia were pre-med. And Columbia had almost a 90% placement rate in medical schools. So, about half my classmates went to medical school. My best friend from elementary school became a doctor. He studied in Israel, of all things, and now practices internal medicine up in Buffalo, New York. Okay, anyway, here's projected healthcare spending. Okay, not everybody agrees with my numbers. And I could tell you all the different ways that these projections, these 10-year projections, my wife laughs at this. It's like you economists make these 10-year projections. Who are you kidding? Well, yeah, we're not really kidding anybody, or we shouldn't be kidding anybody. These projections are as good as the assumptions. But what they're useful for is they can give you a sense of what matters, what doesn't matter, and your internal consistency in what you're doing. The top numbers are from CMS, Centers for Medicare and Medicaid Services, on national health expenditures for the next 10 years, starting this year. So I need to update this, but I haven't gotten around to it. Here are my estimates for what we would be spending with Improved Medicare for All. Improved Medicare for All, by my estimates, would save like $700 billion in the first year. And savings would increase over time because we would be bending the cost curve. The slope on my line is flatter than the slope on the CMS line because I'm assuming we will not allow the greatest inflationary factors in American healthcare, hospital prices and drug prices. I'll talk in a second about how we'll save the money. But bending the cost curve will, over time, increasingly save us money. Here's where the savings come from. These are 10-year numbers. Bending the cost curve, $2 trillion. Administration, $2 trillion. Administration of the a health insurance system, save another $6 trillion. And then $8 trillion from lowering prices for drugs and hospitals. Could we actually capture all those savings at once? No, we probably couldn't. Not from the hospitals. We'd have to do this gradually. Could we capture the savings from drug prices all at once? I think so. I mean, we were in Italy. Wonderful sabbatical I took in Rome. Did some writing. Younger daughter showed up. Graduated college. We bought her a plane ticket. We took her up to Florence. She got sick in Florence, Italy. So we ended up going to the hospital, the oldest hospital, continuously practicing hospital in Western Europe. They had a Fra Angelico mural on it. Wonderful. They treated her. On the way out, my wife waved her credit card at the doctor and said, "How do we pay?" The doctor said, "All done. Ciao, ciao." My wife found a nurse who spoke English better and asked her. She said, "Oh, no charge, Italian hospital, not like America." They handed me 2 prescriptions, a pain med and an antibiotic for a sinus infection, the Z-Pack thing, that you take 6 pills. Okay, so I found a pharmacy. First of all, this pharmacy was across the street from the Duomo, so I sat there looking at the Duomo. And it took just like 5 minutes or less because he didn't have to do the insurance processing. So he handed me the prescription, the drugs. I handed him my credit card. It was $15, 12 euros for these 2 drugs. I went back home to CVS. They would have been $65 in the United States. But the Italian government negotiates drugs. Now, the drug companies, they sell their drugs in Italy. They'll make a profit on Italy. What do they make in the United States? Super profits. Over the last 30 years, the drug industry, big pharma, has been the most profitable sector of the U.S. economy because they've got a stranglehold over us. If you don't take the drugs, bad things happen. And so some people don't, and bad things happen to them. Okay, improved Medicare for all, we'd be spending more on improvement. Even if we were spending more for health care under improved Medicare for all, it very well might be worth it because we'd be covering the uninsured. This is one-year data, 2019. We're covering the uninsured, which costs $67 billion to give health care to the 30 million Americans who are uninsured. 112 billion Americans, $182 billion would remove barriers to access. Let everybody go to the doctor when they need to. We could argue about these numbers. My numbers are lower than the Urban Institute uses. They're actually higher than some other people use. And then Medicaid rate equalization. People who treat Medicaid patients would be paid the same as people who treat everybody else. Why should doctors who treat Medicaid patients face discrimination? Why shouldn't they get as much money for what they do as other people? Something more for administration. How would your lives change? Financially, time management, and spiritually. Financially, people will tell you, oh, your rates are going to go down by 40%. It'll be a disaster. Nobody will want to become a doctor. How many people want to become doctors and deal with the insurance industry? That's another question. But okay, they were not going to go down by 40%. In fact, doctors will get more money under the program, Improved Medicare for All. Not that that's necessarily the point of the program, but it would happen. Yeah, we'd cut your rates by $37 billion to balance reduced cost of billing and insurance-related activities. This is 2019, so it's already a little outdated, but whatever. We'd cut your rates by $40 billion, targeted at doctors at Mass General and elite hospitals who are charging a lot more than everybody else. So they would lose a little bit, but they'll also gain. Everybody will gain. All doctors will gain money because you're going to have the time to treat more patients. You're not going to be spending Friday afternoon talking to insurance companies. Instead, you'll be treating the patients who can now see you because the copays are lower. And $24 billion will go to doctors treating Medicaid patients who will now be treated equally with everybody else. Overall, more money, $10 billion more, will go in physician reimbursements than now. You'll be paid, in effect, we'll be paying you for the time that you are now wasting in humiliating billing and insurance-related activities. Over 8% of physician time in the United States is spent on this billing and insurance-related activities. If I ever find anybody who enjoys that time as much as they enjoy the time they spend with their patients, then I hope they will let me know, because I can't imagine it from what I've heard. Doctors hate this activity. Talking to that snot nose in Omaha, not what they do. And reduced burnout. Burnout has been pointed out to me as a bad term to talk about doctors who can't stand working with the insurance companies. It's actually a tribute to your morality if you resent that time. Okay, what contributes to physician burnout? It's not the lack of yoga. 59% is bureaucratic tasks. Electronic health records, 32% of doctors who report feeling burned out report that electronic health records contributes to it. This is why my family physician dropped out of medicine 5 years ago. Dealing with electronic health records just put him over the top. Lack of respect from administrators, because most doctors now work for somebody else. The idea of the independent physician acting on their own, it's almost gone away. Insufficient compensation matters, but not as much as these other factors. Hours per week spent on administration, 32% of doctors report spending 20 hours or more per week on administrative tasks, like billing and insurance-related activities. Spiritually, this, I think, is the most important thing for physicians. Your money will be okay. You'll have You're not going to have to deal with, the miserable insurance companies. You will be free to practice medicine and to take care of people. When people talk about the most challenging part of the job, when doctors talk about the most challenging part, rules, regulations, difficult patients, yeah. Working long hours, yeah. Electronic health records and rules and regulations and ticking off those boxes. Most rewarding part of your job, the largest element for physicians is the gratitude and the relationship with their patient. When somebody looks at you and says, thank you. You have saved my child's life. You have helped my mother. 24% report being good at what you do. I mean, that's everybody. That's part of the human psyche. We want to do well. We want to do good and get respect for it, and we want to do well. We want to do our work well. You want to prescribe the medicine your patients need. You want to treat the people who need treatment. You want to do the right thing. And when the insurance company tells you to give a different prescription, when tell you to wait a while before sending this person to a specialist, because maybe they'll get better on their own. And in any case, the insurance company, will save money on the float by not spending that money sooner. When they're telling you to treat patients to save money rather than to save lives, that's humiliating, it's insulting, and it undermines your sense of doing the right, being good at what you do. 23% said the most important thing for them is making the world a better place. Most of the doctors I've known, most of the people I knew at Columbia, most of the people I knew at Harvard, even Zeke Emanuel, the oncologist, wants to make the world a better place. We want, almost everybody outside the Trump administration wants the world to be a better place. And we want to contribute to that. That's what Improved Medicare for All will do for you. It will liberate you to make the world a better place, to get the gratitude from your patients, and to do good work as physicians. Well, thank you very much. I'm open to questions.
Fantastic lecture.
Oh, thank you. Thank you so much.
So, what about the arguments that if we do savings that could?
Well, there will be some more bureaucracy in D.C. or throughout the country. I put in $27 billion for that. But the traditional Medicare program is administered at what they would call a medical loss ratio of 98.4%. 98.4 cents out of every dollar spent in traditional Medicare goes to physicians, hospitals, not drugs, it's not covered, but physicians, hospitals, and other providers. Only 1.6 cents goes to those bureaucrats in D.C. Traditional Medicare is administered much more cheaply. They don't spend as much on utilization review, cracking down on you guys. They don't sort patients. They don't advertise. They don't take profits. Traditional Medicare can be cheaper because everybody's covered. You don't have to go and check whether you're still in that plan. You don't have the hundreds of different plans. We get a brochure every year from Unicare, the Massachusetts government's insurance program. It used to be they had 3 plans when I first arrived in '84. Now, no brochure filled, and it's bright colored pictures and everything. Who needs this? But that's where the money goes, and that would go away with one medical plan for everybody.
Yes, sir.
Thank you. Okay, I'll take those in reverse order. The political will, I'll say very little about, because political will is what happens when people get together in their living rooms and elsewhere, talk to each other, and demand action. That's what made the civil rights movement in the United States. That's what made the abolition movement in the 1830s to 60s. And that's what would make the political will. Politicians respond to what their constituents want. The lack of physicians, especially in some specialties, is a real problem. And physicians dropping out, retiring early, leaving the profession to become administrators because they can't stand dealing with the insulting, humiliating conditions that they work under with private health insurance. That's contributing to the shortage. An Improved Medicare for All program, I think, would have to deal with the cost of medical school. We may have to open up the profession, more medical school, maybe give nurse practitioners more responsibility. We have to talk about that. And with a national health system, we could actually do that. But it's not possible now, especially with the general attitude coming out from the top in Washington that the problem of healthcare costs in the United States is because we treat too much. We overutilize, we abuse the healthcare system. If that's your attitude, then you're not going to address the problem of medical school shortages, lack of medical schools. Lack of people applying to medical school because more people are not interested in going into this profession where you have to deal with these problems. The third, that article in JAMA, is a good article. It focused a bit more on overutilization than I would, and it understated, I think, the savings from administrative costs. And as I recall, it also didn't address hospital prices, which is actually the biggest single area of savings from an Improved Medicare for All. So I think it understated the savings, and it looked more, while the total savings they have is actually not that far from what I have, they put a lot more in reducing overuse, which goes back to Berwick and I forget the last name, the other guy, a couple years ago, and they put a very big number on savings from reducing overutilization and improper care. I don't count anything there. I'm not saying that we don't improperly treat. Sometimes doctors practice preventive medicine, not preventive medicine, they practice to avoid getting sued and maybe overdo things. I'm not sure that we can get all that out of the system. Some of it's just baked in. Some of it is inevitable. You make mistakes. And so you send a person to an MRI that's useless. Well, it happens. And, I don't necessarily want to, crack down too much on that. But I think one thing I mentioned earlier, getting longitudinal epidemiological data for the total population, I think, and getting everybody into one system so we can look at how everybody's practicing, I think will allow us to get better data on what works in healthcare and will, over time, improve the practice of medicine. Also, having one system where the insurance company is concerned about the patient's well-being going forward rather than just looking at, okay, got to deal with this person this year and then maybe we'll get rid of them. I think we'll be able to practice better preventive medicine. Yeah. Yes. Yes. Yeah. Yeah. Yes. Well, the realism is a matter of what people do. It's endogenous, not exogenous. But you're absolutely right. We could repeal the restriction on CMS. One agency of the federal government does have a formulary and negotiate. That's the Veterans Administration. and they pay drug prices about half what the rest of us pay. They basically pay the world rates. There's legislation in Congress, there always is, but H.R. 3 may actually be enacted, which would allow CMS to negotiate drug prices. And the Congressional Budget Office has projected hundreds of billions of dollars of savings from this. It is a more tempered approach. It's an incremental approach. It's certainly worth doing, even if we can't do everything else all at once. Yeah, well, that is a policy decision that could be taken with Medicare for All. One of the reasons rural hospitals and safety net hospitals in general are underfunded and vulnerable to closure is because Medicaid rates, these areas tend to treat more Medicaid people and they have more uninsured people. So even if we don't do anything else about rates, equalizing Medicaid and covering everybody, and also they'll have greater increase in utilization because their population is poorer. Even those things will immediately benefit rural hospitals. There's a lot of talk in the hospital industry, the American Hospital Association, that Improved Medicare for All will bankrupt hospitals. And they talk about the rural hospitals. They're going bankrupt under the current system. Yeah. This will help them, even if we don't do anything else. We probably should do something else, just like we should do more to train more physicians. But even if we don't do anything else, Improved Medicare for All will help them. Well, this goes back to the question of what's politically possible. And negotiating drug prices from CMS is something that's been in Democratic Party platforms for decades. The biggest lobbying group in Washington is pharma. They are spending $200 million lobbying Washington this year, according to OpenSecrets.org. 3 of the top 5 lobbying groups in Washington. You wonder why Washington, D.C. is doing so well? It's a lovely city, lots of great restaurants, lots of money. And it's all this lobbying that's coming in. 3 of the top 5 lobbying groups are big pharma, big insurance, and big hospitals. So yeah, we face a major political problem. I am an optimist, and I believe that we're still a democracy, and if people get together, they can overcome the power of money. It's happened before in this country. And I mean, in 1980, who thought that Nelson Mandela would get out of jail and become the president of a free South Africa? In 1962, who thought that we would have desegregated life in the American South? We've won these battles before, and I think we can do it again. Well, everybody switched at some point. But if you're talking about countries with private health insurance systems that switched to national systems, there are 2 in particular in recent times. The first is Taiwan, which, Taiwan is a rich country. And they switched in 95. Chow at Harvard, I forget his first name, was one of the architects of their system. And, he supports a national system in the United States. And their switch was associated with improvements in life expectancy, very small increases in utilization, which is kind of interesting. Canada switched in between 1967 and 1972. Although they don't cover drugs and there are some other limits. But their system also, their switch was associated with better control over healthcare prices than in the United States, and relatively small increases in utilization and improvements in life expectancy. The gap between the United States and Canada in life expectancy was something like 1 year in 1971. It is 3 years now. So these were successful switches. Of course, it's a big deal. Britain switched in 47. And the Minister of Health in the Attlee government famously said about how they got the doctors on board, we stuffed their mouths with gold. But it was, the National Health Service is so popular that even right-wing Tories say they support it. Oh, thank you.
We sent you home with and yours reads Gerald Friedman, 2019 George Pedigo.
Oh, that is so sweet. Thank you so much. Oh, this is great. Oh, thank you.
Now it's picture time.
Oh.